Hello, everyone. So in the interest of time, before I get to my questions and our discussion, I'm just going to ask each of you panelists to just quickly introduce yourself. Some of you we've already met today, but new people might be streaming, so it might be helpful for them to just hear a little bit about who you are. So let's start at the end there with Dr. Malone.
Is this on?
It is.
Will Malone, I'm an assistant clinical professor of endocrinology.
Okay, so my name is Anne, and I'm the team leader of the Norwegian Transgender Youth Clinic.
Erica Anderson Still, clinical psychologist.
Laura Edwards-Leeper, clinical psychologist also in private practice currently.
Riittakerttu Kaltiala, professor of adolescent psychiatry from Tampere, Finland.
And Mikael Landén, professor of psychiatry from Sweden.
Thank you, everyone. Thank you for being here. So we heard just earlier today, a little bit ago, from Dr. Kaltiala, that in Finland, puberty blockers are being offered for a narrow range of patients, and only after a failure of first-line treatment, which is there comprised of psychosocial support and psychotherapy. In England, puberty blockers was recently announced just a few months ago, I believe. The puberty blockers will be limited to the research context, though we're still waiting to learn more about how the research will be structured, who exactly will be included. There's still some questions there, but it does look like they are stepping back to some extent, to a great extent, actually. Things look a little bit different in the United States. We have much more permissive policies here at most gender clinics. So the main reasons for the limitations that we're seeing, I think by now are clear enough. Namely, the poorly understood dramatic increase in youth presenting at gender clinics, the conclusions of systematic reviews calling for caution in the prescription of medical interventions, and the differences in the patient profile as compared to the patients that were originally treated by the Dutch in the two seminal papers, primarily. So for example, the age at the onset of dysphoria, more complex mental health histories, psychiatric comorbidities, we've heard about that already. So one thing we haven't heard about yet, and my first question is for Dr. Anne Wæhre. Can you tell us a bit about how you and other clinicians and researchers in Norway are approaching the use of puberty blockers?
Okay, thank you. So I've been working within this field for 10 years, and at that time in Norway, we are less than 50 patients. So in Norway, we have 5 million people, and the first child admitted to the hospital was in 2002, and a biopsychosocial assessment was a normal treatment. All patients coming to Norway, they need to go to their local mental health outpatient clinic before coming to the national team. So when I started 10 years ago, I was very eager to start working with the Dutch protocol. I went to European conferences, and I was told that was the right way to treat patients. So we started with puberty blockers. First one, I think, was in 2006, but it increased in 2015 and 16. But then suddenly, at the same time, we saw the same increase, which we have seen in all countries last years. And what we noticed was that some of the patients, especially those who started puberty blockers late in puberty, they got severe withdrawal symptoms, and some of them get tremendous weight gain. And for sure, we saw that almost none of the patients, it was a pause. They all almost went on to cross-sex hormones. So that made us start to talk more openly to the public, to the press about the increase, and we were worried about the increase. We didn't really understand what this was. So, but at the same time, we had a really strong LGBT community in Norway, which has been doing enormous work into the health authorities, which resulted in 2020 in a guideline which was based upon human rights. it is specifically told in the guideline that this is not based on the evidence-based, but it is a more human right-based. That was 2 years ago, but this year in March, some of you heard about the UCOM report, which is a governmental, it's a governmental health investigation board, which are telling they have done a review and looked upon the evidence base, and their suggestion is that all treatment should be under trial. So that is where we are now, just about how to start this trial. Yeah.
Thank you. So my next question is for Mikael Landén. You co-authored a systematic review of the evidence underlying hormonal interventions for the treatment of gender dysphoria. The review examined 24 studies, 21 of which looked at puberty blockers, with the remaining 3 having focused on the use of cross-sex hormones. The review, your systematic review, focused on several weaknesses in the underlying evidence, including the lack of long-term studies and the absence of randomized controlled trials. One of your team's conclusions is that the long-term effects of puberty blockers on psychosocial health is unknown, and that, consequently, and here I'm quoting from the review, treatment in children with gender dysphoria should be considered experimental treatment of individual cases rather than standard procedure. So my question is, what were the main weaknesses your team found, and how do you think future research might remedy these weaknesses?
So there are 2 answers to that question. One is a more traditional medical answer, that the studies were poorly done, and I will elaborate somewhat on that tomorrow.
Yes.
But it revolves around regression to the means and the high dropout rate and selection bias and so forth. So we would never accept that in any other field, in any other medical field. But the other aspect is that even if these studies were properly done, they wouldn't answer the question we need to answer: what would have happened if we did nothing? And I realized that that's super. I mean, so a placebo-controlled study doesn't answer that question either. We would need to compare 2 similar countries, for example, Norway and Sweden, or Finland and Sweden, where puberty blockers were allowed in one country and prohibited in the other country, and look at the outcomes. So I'm very concerned because proponents of this treatment are listening in. They are understanding that the scientific quality is poor. Let's do it better. And that will happen. And long-term outcome studies will appear. But they will not answer that key question: what would have happened if we did nothing? I mean, watchful waiting and psychosocial support and all that.
Yeah, thank you. If I could just follow up. In your review, I believe with respect to hormones, I'm not sure if your team suggests this with respect to puberty blockers as well, but you think we can do controlled trials but without placebo. Can you say, is that what you were just referring to in looking at countries, comparing countries, or what's the objection to using placebo?
The objection being that I don't know of any other medical conditions where patients so much want the treatment. I mean, maybe psychotherapy, and psychotherapy is actually a good example because there we have waiting list studies, and there are not a single waiting list controlled studies in the whole psychotherapy scientific literature that has been negative. All are positive. And you can do whatever you want. You can give them Heinz ketchup if you want to, and put the other group on waiting list, and the ketchup group will fare better. No, I'm not joking. That will happen. Waiting list is nocebo. So I don't know how to get around that.
Okay, thank you. Will, I'd like to ask you, or Dr. Malone, I'd like to ask you a question you're an endocrinologist, and so you've worked with patients for years, and you've been watching the controversies over this area of medicine also for years. And what are your primary concerns as a practicing clinician with respect to puberty blockers?
Yeah, so the lack of convincing evidence that these interventions improve mental health is highly problematic. So, as someone who prescribes lots of different hormones to lots of different people, I've got to be certain that the likelihood of benefit outweighs the likelihood of harm. And in this situation, I've been asking and asking and asking for evidence of benefit from these interventions. And we can't find any convincing evidence. It's low certainty or very low certainty. The consequences of puberty blockade are significant. They're the first step in a sequential pathway. We've heard that most kids go on to cross-sex hormones after puberty blockers. So as an endocrinologist, that first dose of a puberty blocker may very well end up with that child being sterilized and having sexual dysfunction later in life. So that decision-making point is extremely important, and I want proof that it's going to improve that person's life before I put them down that pathway.
Yeah. Thank you. So that is a good segue for my next question. And here I'm going to ask the question and give each of you an opportunity to answer, and I can start from Mikael. Here's the closest to me here. So opinions on the use of puberty blockers vary widely and have become in some countries, and perhaps most notably in the United States, an intense point of moral disagreement and, of course, political disagreement as well. The strongest advocates of medical intervention believe it is wrong for clinicians to require mental health assessments before prescribing puberty blockers, viewing such gatekeeping as undermining patient autonomy by wrongly pathologizing a patient's desire to more fully realize their identity or to express who they really are. And so there's these sort of deep autonomy-based arguments that you see among some clinicians and bioethicists. And Dr. Anderson and Dr. Edwards-Leeper wrote about this a few years ago in the Washington Post with a focus on mental health assessments. So on the other hand, the strongest critics of medical intervention believe these treatments should be legally banned, pointing to the risk of infertility and sterility. Sometimes it's a very high risk, in fact, right? If you start on blockers and go on to hormones, surgery, obviously. The risk of sexual dysfunction, increased risk of later surgical complications due to not enough tissue, as well as uncertainties with respect to bone density and cognitive development. And between those two positions, there are, of course, plenty of positions one might occupy, right? Between the maximally permissive position and the maximally restrictive approach, right? Lots of positions in between. So I would like, if you're willing, for each of you to share your thoughts on how you think clinicians should be approaching this question.
Should I start?
Yeah, sure.
So I think you need to decide if you view this as a human rights issue or as a medical issue. If you see it as a human rights issue that patients decide, then the issue of regret or side effects are irrelevant because we need to respect patient autonomy. And then people would, of course, say, but these are children. So that needs to be discussed. But if you see it as a medical issue, then you should be able to predict, if we were able to predict which child will eventually go on to require sex reassignment surgery to have a good quality of life. If that was possible, and it might be possible in the future, then puberty blocking treatment would actually be beneficial. And then we would just do as we always do in medicine, try to predict which patients will benefit from this treatment and how do we minimize side effects. And the side effects are there, but if the benefits are huge, they are actually not that severe. And I'm, full disclosure, I am on the medical side, I see this as a medical problem, and I don't think the evidence is there. I don't think we can predict which patient will benefit, and therefore we should be very careful and only do it in the framework of a clinical study.
I would like to emphasize that proper assessment is a basic practice in basic activity in any medical practice. You first assess the patient, and then you define what treatment options there are based on the assessment that's resulting in diagnosis, but not only the diagnosis, but also considering this particular diagnosis in the circumstances of this particular patient. There is hardly anything in any treatment in medicine that would automatically be the consequence of a diagnosis, because the diagnosis is the kind of a first step or an important step, but nevertheless not defining that if you have this diagnosis, then you absolutely need to have that treatment, because the treatment options are always considered from the particular patient's specific situation. And therefore, I think that of course, if we keep this as a medical question, then appropriate medical assessment is an imperative in any medical practice. It's malpractice if you simply give people different treatments without assessing them at all. And reaching a diagnosis is not the same as meaning that now a specific treatment will follow, because it's from the patient's situation necessary to evaluate. So if it, on the other hand, could think of this as a human rights issue, then I have difficulties in conceptualizing it really as a human rights issue that a child in early adolescence, in age of 12, for example, could just be freely able to decide about such a rough future consequences as infertility, sexual dysfunction, loss of bone health, and a lot of also more immediate nuisances that may follow that are not discussed enough, the side effects of being on blockers and producing actually early menopause. So this has not been discussed, and the parents have not been informed about it, and the children are very unlikely to be able to understand even if they were informed about these issues. So this can't be really, to me, a human rights issue that a child be allowed in contemporary society to lightly decide to destroy their future health. And on the other hand, if it was not a medical issue at all, then why do we need the medical profession here? People could buy this over the counter and use as they ever wish. If it's not a medical question. If it is a medical question, then we have a great amount of responsibilities in the medical profession to assess the patient properly and define the treatment options from the perspective of the situation of this particular patient.
Thank you.
I think we see in the clinics for sure that some patients... Oh, I'm sorry.
No, you go.
Sure? Okay. We see for sure that for the right patients, with those with childhood onset gender dysphoria, worsening puberty, with good function, parents that look after them, the puberty blockers do good. They get less dysphoria, and they have the same stable function after. However, I think yesterday, Senja, you asked a really good question in the last point of the program. Where do we move now from the low quality evidence base to guidelines? And there was this gentleman from Belgium, I think, who, yeah, it's you. Yeah, you talked about the use of utilities to find out more what patients, parents, and professionals could use to look into, for instance, how they evaluate side effects at infertility. I think that was really interesting, because now we are there that we need to move on from this low evidence base to guidelines that we can use.
Okay, so my perspective on this is that there are a lot of unknowns with the puberty blockers that we should definitely be doing more research to better understand the side effects. There's no question in my mind about that. But my main concern really is the way that it has evolved in the United States to be something that is completely seen as completely reversible, and therefore does not need any kind of assessment, as you were speaking to, and it should be given to any child with any degree of gender confusion. And so that was never the way that we started the program in Boston. That was never the idea that I learned from the Dutch. The Dutch were very clear that the main goal of the blockers, which I haven't really heard today yet, but is to buy time, to give the kid more time to continue to explore, which, by the way, in the affirming model, we always talked about exploration being critical, but to explore their gender more thoroughly as they cognitively matured so that they could make the best decision going forward regarding permanent medical interventions. So that was the primary purpose of the blockers when I helped bring them to the United States. The secondary kind of icing on the cake, I guess, was for those who did continue on that path. They were able to transition more easily and be perceived by others in society as the gender that they identified with because they hadn't gone through their puberty that they didn't align with. But that was not the primary reason for the blockers. So I just want to make sure that that's really clear. But sadly, this is one of the many things I feel like I've been banging my head against the wall over the years with talking to colleagues in the field, where we've strayed so far away from that approach to care that it's gotten to the point that, most of the providers I work with, the medical hormone prescribing providers, do not require any sort of mental health involvement prior to blockers because it's seen as completely reversible. When I've done assessments with young people where, it was a gender nonconforming assigned girl who just was scared to death of going through puberty, didn't want to have periods, didn't want breast to develop, that was not an appropriate candidate for blockers in my mind. So my answer was no, we need to face your anxiety, not avoid your anxiety. But that is not what's happening. So the other piece that's not happening is that parents, we're not seeing this as something that really parents are the ones that have to consent to for children at the age of 10 or 2. We cannot expect a child at that age to understand the long-term implications if they do go on to start hormones later and the fertility implications and all of the other things, the sexual functioning and whatnot. So parents have to be made fully aware of all of the risks that we know of and also what we don't know, so that they can make the best decision for their child. Obviously, we're talking to the child too, but I can't think of a child who I felt like at that age was able to truly consent to this kind of medical intervention. So it falls on the parents. We have to involve them. So by not involving them, which is another thing happening, we are taking away the protection that parents offer to their children. And so that greatly concerns me. So I guess that's what I'll say for now.
So I think we have time to finish this question. I just wanted to follow up with you on your comment. Maybe this is a question that's better put to a medical historian or a sociologist, but if you have any thoughts, we'd probably love to hear them. You noted that early on when there was more gatekeeping, it was understood the rationale was to give a child more time to think, and that as time has gone on, now they're prescribed quite easily. Do you have any explanation for how that happened, or how the thinking changed among U.S. clinicians, such that the basic rationale that was adopted early on has kind of been dismissed or rejected?
I would say it's a couple of things. One is the fact that it is considered to be completely reversible. And so that's just what's relayed to the family, and the parents, they trust their medical provider. And then I also think, I mentioned this yesterday, but the medical hierarchy in the United States puts the medical doctors at the top. And so I think that the mental health people involved in this care are not always valued in the way that they should be. And we're really the ones that are trained to do the kind of assessment needed to determine, where is this dysphoria coming from? Where is the child's confusion coming from? How do we understand the family dynamic to best give recommendations to the family? So I think it's those things and maybe others.
Thank you. Go ahead, Riitta, follow
Well,
up.
I just wanted to comment on something that you said about the early talk about buying more time or giving them more time. And it seems to have turned out that actually most of the kids who are put on blockers actually proceed to cross-sex hormones, which means that it's the first step in this treatment path, not kind of buying time. And the second point that then I also remember that back 10 years ago, it was a lot of talking about giving them time to mature and decide about the more irreversible treatments with a more mature brain, not deciding about that in age of 12 or something like that. But what we just heard about the compromising effect on cognitive and emotional development, it doesn't seem to give the possibility to mature and then decide with more mature mental abilities. So I think this has been at least partially compromised and needs attention as well.
Can I just speak to that very quickly? I mean, this is one thing we may disagree on. And this is based purely just on my clinical experience. But I do think that as young people go from, age 11 or 12 to 14, 15, even on the blockers, in my own clinical experience anyway, they are able to better think about the long-term consequences. They're able to think about fertility. We do need research on it, clearly, but I think that I have not seen some drastic change to their ability to think through decisions. In fact, I've seen them be able to engage in those conversations in a more mature way. The problem is that they're not engaging in those conversations, and then unless they happen to be with a therapist who is encouraging that. In clinics that I've worked in, we never really required the patient to see a therapist during the time they're on the blocker. So then sometimes they would get the implant for 2 years, they would come back, they hadn't done any exploration. And so then the medical doctors are concerned about bone health, and we have to get the implant out and you have to make a decision like next week about which puberty you're going to go through. And so then they called me in to say, okay, Laura, help them figure out, in the next week, what puberty they want to go through. And I'm like, well, why weren't they seeing a therapist during those 2 years that they were on the blockers? That was the whole point of the blockers, is to give them more time to explore what, and understand the long-term implications for the hormones.
Yeah, I wanted to give.
I can answer. So I'll go next. So I'd like to see medical societies, back to your original question, generate guidelines that accurately reflect the evidence. Ethical healthcare is evidence-based. Perhaps that should be a human right. And I think, given the evidence that we currently have, if a proper balancing of benefits and harms is done, those guidelines would likely come out and say recommend against, based on what we know. And that's how I feel things stand currently.
Thanks, Dr. Malone. Dr. Anderson, did you want to comment on this?
Well, is it on? Can you hear me? Yeah. So I'd be a fool if I took a position different than Laura today. I don't think I'm a fool. I certainly stand with her in terms of the critical importance of evaluation. I would say, frankly, I started out cautious about puberty blockers years ago. I continue to be cautious about puberty blockers. I've gotten more cautious about puberty blockers, and after today, I would yet be even more cautious about puberty blockers. But I have recommended them, to be honest, for patients where the patient fit the criteria that in the Dutch model, and that it seemed like it was an important step for that child. We all are humbled, I think, by the fact that we don't have perfect protocols. None of us in the room can predict who's going to be persistently trans indefinitely, and I'm humbled by that every time I am asked by parents, what do you think, and what do you recommend? And when I'm asked by young people, well, are you going to recommend to my parents that they approve whatever? But I still am concerned that we may have a technology that could be useful in selected cases. I think I'm chastened by the the evidence, systematic evidence reviews of my Nordic colleagues and in the UK, and I want to keep learning. So I'm still my version of an affirmative clinician, but increasingly cautious.
So I see some hands up, but I think unfortunately we are out of time. So I want to thank my panelists.